Okay, so we are going to switch to HFpEF as our segue. So we've talked a lot about the systolic heart failure. And so we'll go through the first pre-test questions, and then I'll introduce Maggie. So question number one is you have 2 heart failure patients admitted to the CCU. They each have a wedge pressure of 28, a right atrial pressure of 20, a heart rate of 80, and an output of 3.5 liters per minute. Which will achieve greater improvement in cardiac output with sodium nitroprusside? Patient A has a ventricle that's 42 millimeters, an EF of 60, and a blood pressure of 180/50. And patient B has a really dilated left ventricle, an EF of 13, and a blood pressure of 90/70. Which one's going to improve their cardiac output best? Learning opportunities, we like to call those. All right, question number 2 is a 72-year-old male who is obese with a BMI of 54, type 2 diabetes, sleep apnea, and is short of breath with minimal exertion. The NT-proBNP is 100. EF is normal size, normal function with mild RV enlargement. The E to A ratio is 1.6 with a deceleration time of 125 milliseconds. E prime is 0.04, which gives an E over E prime ratio of 20. Pulmonary vein velocity is a 0.5 in systole, 0.8 in diastole, and the pulmonary artery systolic pressure is 60 millimeters of mercury. That echo suggests which of the following? High filling pressures and normal LV relaxation. B, normal filling pressures and impaired LV relaxation. C, high filling pressure and impaired LV relaxation. D, normal filling pressure and relaxation. Or E, group 3 pulmonary hypertension due to obstructive sleep apnea. Okay. Question 3 is a 74-year-old male presenting with slowly progressive exertional dyspnea. He has treated hypertension with no chest pain. He never smoked. He had a normal angiogram a year ago. He's on HCTZ, enalapril, and amlodipine. His blood pressure is still 160. His pulse rate is 65. His heart is big, but his lungs are clear. He went 4 minutes on an exercise stress test to a heart rate of 150 with severe dyspnea, but no ischemia. His echo shows normal, or so it's an enlarged LA, normal EF, normal RV, and he gets that mitral inflow velocity. The best next step would be to A, change the HCTZ to furosemide, B, add a beta blocker, C, stop the enalapril, D, do a chest CT looking for pulmonary embolus, or E, pulmonary function tests. Okay, so Dr. Maggie Redfield, professor of medicine, worldwide leader in HFpEF and diastolic function understanding. She directs our heart failure program here and has done just a fabulous job of leading that enterprise. It encompasses, it was our really first comprehensive service line of inpatient, outpatient, transplant services put together, and Maggie has really been a great champion for that, and she's going to talk to us about this confusing entity of heart failure with preserved ejection fraction. Thanks so much for letting us hear your words of wisdom, Maggie.
Well, y'all did pretty good on those questions, so that's good, but we'll address the ones that were less than 99%. So we're going to talk about HFpEF, and we're going to spend some time talking about the pathophysiology. And when you think about treatment, we have this unifying pathophysiology for HFrEF that has guided what therapies have been tested and what therapies were successful. And in the past, we kind of thought the unifying pathophysiology of HFpEF was that patients had hypertension and they got concentric remodeling and hypertrophy and diastolic dysfunction and fibrosis, and they got heart failure and neurohumoral activation, which then perpetuated the adverse remodeling. So it was sort of very similar to the pathophysiology of HFrEF. But that didn't really work out when it comes to therapy, as we'll go over. And so a new kind of pathophysiology paradigm has emerged where the concept is that all the comorbidities that patients with HFpEF have, diabetes, obesity, hyperlipidemia, sometimes lung disease, and other comorbidities, cause coronary microvascular inflammation. And this allows inflammatory cells to migrate through the microvasculature into the myocardium and drive fibrosis, and importantly, causes oxidative stress in the myocardium. And that limits NO cyclic GMP signaling, and that has adverse effects on ventricular remodeling. It perpetuates hypertrophy and perpetuates myocardial stiffness. So this is sort of the new paradigm, kind of keep in mind as we go through today's discussion. So just to review real quickly, when we think about the ventricular geometry in HFpEF, we first look and see what the calculated LV mass index is to see if the patient does not or does have hypertrophy. And then we look at the relative wall thickness. And remember, that's 2 times the posterior wall thickness divided by the end diastolic dimension. Patients, and that gives us these 4 kind of categories of ventricular geometry. And patients with HFpEF tend to have either concentric remodeling, a small cavity and thicker walls without LVH, actually meeting the LVH definition, or actual concentric hypertrophy, in contrast to HFrEF, where they have the big dilated ventricles and the thin walls. But keep in mind also that somewhere around 40% of patients with HFpEF don't have an increased relative wall thickness or an increased LV mass index. But if they do, look for smaller cavity, thicker walls, that concentric remodeling or hypertrophy. So that's LV structure. Let's now think about systolic and diastolic function in HFpEF. And it's really important when we get to therapy to understand this and understand why patients with HFpEF may react to a certain therapy differently than patients with HFrEF. And we have to go a little bit beyond just ejection fraction. So we look at the end systolic and end diastolic pressure volume relationships. And how that is done is that you have to measure pressure and volume simultaneously to get that pressure volume loop that I know you've gone over a lot. And again, that's isovolumic relaxation, diastolic filling, isovolumic contraction, and ejection. And you do that, and then you put a balloon in the IVC and you blow it up and you rapidly drop preload. And that defines the end systolic pressure volume relationship. End systolic pressure drops as you drop preload in a linear fashion. So that's the end systolic pressure volume relationship. And that is a measure of systolic function. And end diastolic pressure and volume drop simultaneously, and that gives you the end diastolic pressure volume relationship, which is curvilinear in contrast to the usually linear end systolic pressure volume relationship. So end systolic pressure volume relationship, you get that that slope of the end systolic pressure volume relationship, which is end systolic elastance, which is the stiffness of the ventricle in systole and a measure of systolic function. And then you get the end diastolic pressure volume relationship, which defines the relationship between end diastolic pressure and end diastolic volume. And that's a curvilinear relationship, so it's an exponential equation, that pressure goes up according to end diastolic volume in an exponential fashion. And we look at that beta, which is the coefficient in that equation, and that's the stiffness constant. So it tells you how steep that curvilinear relationship is. And the higher the beta, the higher diastolic pressure goes with any change in end diastolic volume. So it's a measure of diastolic stiffness. Now, also, we look in that relationship at vascular function. So we look at arterial stiffness, and we calculate something called arterial elastance or arterial stiffness, since it's the relationship between the end systolic pressure and the stroke volume. And chronically, when patients have increase in their vascular stiffness, their ventricle remodels to match that. So end systolic stiffness is matched to the changes in the vasculature chronically, all right? So what are the changes in HFpEF? Well, everything goes up. The end systolic, or the arterial elastance is elevated chronically. That leads to increases in end systolic elastance, or the end systolic pressure-volume relationship, and you get an increase in the end diastolic stiffness, or the diastolic stiffness, and that's the beta. So what that means is with those changes that occur chronically, you maintain end diastolic volume and end systolic volume. Those don't change. You maintain your EF, but your function's very different, so that at any given end diastolic volume, because of the increase in diastolic stiffness, your end diastolic pressure will be higher, and at any given end systolic volume, your arterial pressure will be higher. So those are the changes in HFpEF: increased arterial, end systolic, and diastolic stiffness. So that's kind of chronic remodeling and changes, but these relationships have implications when there's an acute change in load. So the response to acute change in afterload, if you give a vasodilator or somebody steps into a hot tub, is dependent on their function as defined by their end systolic pressure-volume relationship. So when we give a vasodilator, we expect the pressure to drop, the systolic pressure to drop, and we expect the stroke volume to increase. But how much those two changes occur will depend on the systolic function, what their systolic stiffness or their end systolic elastance is. So Barry Borlaug very nicely demonstrated the importance of this for therapy in real patients. He took a group of patients with systolic heart failure. They have a very low end systolic elastance, and he gave them nipride to drop their arterial elastance by about 0.8. And these patients got a small drop in their end systolic pressure and an increase in their stroke volume of about 23 mils. He then took a group of diastolic heart failure patients, very high end systolic elastance, dropped arterial elastance or afterload by the exact same amount, and got a much bigger drop in end systolic pressure and a much smaller drop in end systolic volume. So the answer to that question can be shown here. Despite a much lower blood pressure, patients with systolic heart failure are going to respond more favorably for afterload reduction in terms of their cardiac index. So that's vascular, LV systolic, and LV diastolic function in terms of diastolic stiffness. But the other important component of diastolic function is LV relaxation. So we've talked about stiffness. Now we're going to talk about LV relaxation. And these are just two pressure tracings, one from an individual with a normal blood pressure and one from an individual with a severely elevated blood pressure. And when we're looking at relaxation, we're talking about early diastole, the pressure drop during the isovolumic relaxation period from end ejection to mitral valve opening. And you can see that relationship is sort of curvilinear. And you can see the relationship in the patient with a very high blood pressure. And are they different? Is relaxation different in these two individuals, and how do we quantify it? Well, in the cath lab, one can calculate the time constant of isovolumic relaxation. And remember, it's a curvilinear decay in the pressure trace. So what they do is you take the log of the LV pressure and graph it against time instead of just the LV pressure. And that gives you two linear equations. And you can see that the individual with the normal blood pressure, that relationship is much steeper sloped than the individual with the very high blood pressure. And you take the negative inverse of this slope, and that's something called tau, the time constant of isovolumic relaxation. So in the hypertensive patient, it's very long, the time constant, and in the patient with the normal blood pressure, it's very short. So the longer your tau, the slower your relaxation. A normal tau should be less than 40, and generally we think that relaxation is complete by about 3.5 times tau. But what does this all mean in terms of understanding how your patient's doing, and can impairment in relaxation actually lead to elevated filling pressures? Well, I'm going to walk you through this. This is just one cardiac cycle. It's just an LV pressure trace from end ejection, so this is isovolumic relaxation, filling, isovolumic contraction, and ejection. So it's just one LV pressure trace at a rate of 60 beats per minute, so the R interval is 1,000. And this is what it looks like in an individual with a normal tau, and this is what it would look like in an individual with a very prolonged tau. Now you see that even though tau is very prolonged, relaxation is still complete pretty early in diastole, and you still have all this time to fill the ventricle. So if you look at what that means for the pressure-volume relationship, this marked elevation in tau really didn't change that very much. Early diastolic pressures are a little bit elevated, but end diastolic pressure and mean diastolic pressure are not really changed at a heart rate of 60, even though relaxation is very impaired. Now you take that same individual under tachycardia, where the heart rate's 120 beats per minute, the RR interval is now 500 milliseconds, and you can see the time scale is very different from the 60 beat per minute tracing. Here's what it looks like with normal relaxation, and here's what it looks like with a tau of 80. And you can see now at the faster heart rate, relaxation is not complete till almost end diastole. And this has very different implications for mean diastolic pressures. You can see here now the mean diastolic pressures are markedly elevated during tachycardia. So, relaxation take-home points. Relaxation's impaired in HFpEF. We quantify it by the isovolumic relaxation time constant, or tau, which is derived from the LV pressure decay during isovolumic relaxation. Severely impaired relaxation doesn't necessarily change diastolic pressures at low heart rates, but can result in marked elevation in diastolic pressures at high heart rates, such as during exercise or with tachycardia during AFib. So we've talked about the left ventricle and the vasculature. Now let's talk about the pulmonary vasculature in the right heart and HFpEF. And I know Dr. France most likely showed you and reviewed these concepts when he was talking about pulmonary hypertension, that in group 2 pulmonary hypertension, which is due to left heart disease, which includes HFpEF, you can have pulmonary hypertension just due to the elevation in the pulmonary venous pressures, which gives you a high pulmonary artery systolic pressure, a high wedge pressure, but your pulmonary vascular resistance is normal. But with time, this chronic pulmonary venous hypertension causes some hyperreactivity of the pulmonary arterial circulation, and you can actually get a modest increase in your pulmonary vascular resistance, even with just group 2 pulmonary hypertension. Nowhere near as severe as in group 1, but it can be elevated in the 3 to 5 range. And then if heart failure is very severe, you can actually get true pulmonary vascular remodeling that can cause a fixed increase in pulmonary vascular resistance. So pulmonary hypertension is one of the sequelae that you get from chronic pulmonary venous hypertension in HFrEF and HFpEF. So you're going to see an increase in LA volume, an increase in pulmonary artery systolic pressure, and with time, chronic pulmonary hypertension can have adverse effects on the RV in HFpEF, and about 20% of patients with HFpEF will actually have some RV dysfunction and enlargement. Now, I didn't have time to go over all the other components of the pathophysiology. We've concentrated more on diastolic dysfunction because I think that's what's going to be on the boards. But good to know that there's other components of the pathophysiology. We talked a little bit about the increased vascular stiffness and the pulmonary vascular dysfunction, but it's important to recognize that when patients with HFpEF exercise, they don't dilate their periphery appropriately. They have endothelial dysfunction, so they have impaired vasodilatory reserve. And even though their EF is normal at rest, they actually have subtle systolic dysfunction if you measure other markers. So they have increased systolic stiffness, but their actual contractility is subtly impaired. That's sort of extra point of understanding. Don't worry about that too much for the boards. And importantly, when they exercise, they do not increase their EF appropriately. So they have impaired systolic reserve. So because they can't dilate their periphery appropriately and they can't increase their contractility appropriately, they have this impaired VA coupling reserve which contributes to their exercise intolerance. They have arrhythmias, and the two big ones are chronotropic incompetence and atrial fibrillation. And they get atrial dysfunction. They have this very stiff left atrium that can lead to giant V waves in their wedge tracing, which is not due to mitral regurgitation, but rather due to their stiff left atrium. And they get neurohumeral activation and RV failure, just like patients with systolic heart failure do. And they have abnormalities in their peripheral muscle physiology as well that can contribute to their exercise intolerance. And all these things present initially with exertional dyspnea, but over time can lead to actual end-stage heart failure. So that's the pathophysiology. Let's talk about outcomes briefly. Lots of observational studies show that outcomes with HFpEF and HFrEF are similar, but and that's in terms of mortality, overall mortality, and in terms of rehospitalizations and hospitalizations with heart failure. If you just read the clinical trial literature, however, the type of HFpEF patients that make it into large randomized clinical trials tend to have a little better outcomes, probably fewer more comorbidities and younger age. So if you look at trials that have compared outcomes in HFpEF and in HFrEF when the trial enrolled both types of heart failure, like the DIDGE trial or the CHARM trial, outcomes are a little better with HFpEF than HFrEF. What is very different, or somewhat different, is what patients with the two forms of heart failure actually die of. And in HFrEF, about 40% of patients die of something other than their heart failure. About 40% die of complications from coronary artery disease, and about 20% die of heart failure or stroke. A similar proportion of HFpEF patients die of heart failure or stroke, but they're more likely to die of non-cardiovascular causes and less likely to die from coronary artery disease. So a little bit difference in the cause of poor outcomes. Now they wanted me to review what I know the echo people have already gone over, and that's the Doppler assessment of diastolic function, and I'm going to try and more incorporate it into clinical decision making in this review for you. So the first abnormality we think occurs in HFpEF is impaired relaxation. And we look at that by looking at the Doppler tissue inflow or the Doppler tissue imaging of the mitral annulus. And we see that the E prime velocity is decreased in patients with impaired relaxation. And again, that's because in systole, the annulus comes down to the apex, and then in early relaxation, it moves back up towards the base, and the speed which that occurs, or the E prime velocity, is basically related to myocardial relaxation. So if that velocity is lower, relaxation is slower. Then we also look at the mitral inflow, and because relaxation is slower, the pressure gradient between the left atrium and the left ventricle during early diastole is reduced. And the pressure gradient there is what drives the velocity of early diastolic filling, or the E velocity, and the speed which flow stops, or the deceleration time. So you have a lower E velocity and a longer deceleration time in impaired relaxation. So impaired relaxation, think low E to A, low E prime, and long deceleration time. And because the E velocity is decreased and the E prime velocity is decreased, generally the E to E prime ratio, a marker of filling pressures, it remains within normal limits. Now, after you get impaired relaxation, we believe that there's an evolution of impairment in diastolic function, so your diastolic stiffness then gradually increases. This leads to impaired filling, which drops your cardiac output, which triggers sodium and water retention, and increases in your LA pressure, which can restore filling and cardiac output, but at the cost of pulmonary congestion. So at any moment in time in a HFpEF patient, their diastolic filling patterns will depend on what their LA pressures are and how much impaired relaxation and how much increased stiffness they have. And that's what's going to give them their specific filling pattern. So I think what you have to look at is this progression in diastolic dysfunction as defined by Doppler. And keep in mind that what we believe is happening is that LV stiffness is increasing during this progression and atrial pressures are increasing. So in normal people, with brisk relaxation, they're sucking the blood into their ventricle, but in the presence of impaired relaxation and increased diastolic stiffness, they have to push the blood into their ventricle with higher left atrial pressures. So during this progression, the E prime relaxation continues to worsen, so the E prime velocity goes down. But because atrial pressures are going up, the E velocity goes up. Now, if you can, in a patient with this sort of pattern, quickly drop preload by doing a Valsalva maneuver, you will reveal the impaired relaxation pattern. But if they're very high filling pressures, the potency of the Valsalva maneuver to drop pressures is less, and so you will not see that EA reversal. So we call that a fixed restrictive pattern. And because the E prime stays low and the E goes up, you'll get a high E to E prime velocity. Now, if that E to E prime ratio is greater than 15, that's fairly specific for high filling pressures. Or if it's less than 8, it's fairly specific for normal filling pressures. Unfortunately, anything in between, it's about 50-50. So these are good guidelines. They work a lot of the time, but they're not 100%. And because the other thing that happens as LA pressures go up and the ventricle has increased diastolic stiffness is the deceleration time shortens. And this is really just the Doppler equivalent of the dip and plateau sign. As your ventricle is very stiff, with filling, the diastolic pressures come up very rapidly. So that's that dip and plateau sign. And so that abbreviates early diastolic filling, and you have a short deceleration time. So if you're looking for high filling pressures, think high and short, high E to A, high E to E prime. See if they give you EA reversal with Valsalva and short deceleration time. If it's less than 140 milliseconds, that's fairly specific for very high filling pressures. Clinical Pearl, keep in mind we're making a lot of measurements in the echo lab in any one patient. And the more measurements you make, the greater the statistical chance that at least one of them will be abnormal. So don't pin anything on just one thing. You're looking for concordance. You're looking for things to fit together. High E to A, short decel time, low E prime, high E to E prime, LA enlargement, so a little bit of pulmonary hypertension. The more of those you have, the more confident that you can say that these patients have high filling pressures. All right, so that was a quick review of echo. Now we're going to try and interpret these and talk a little bit about the presentation and interpretation of testing in HFpEF. Well, if you're working in the hospital and a patient comes in with florid heart failure, you know, congestion on the chest x-ray, they're dyspneic at rest, they can't lay down, that's pretty easy to make the diagnosis of HFpEF if their EF is normal. And keep in mind, in the hospital setting, common precipitants of decompensated HFpEF are a hypertensive episode. Don't forget to think about renal artery stenosis. That's RAS, renal artery stenosis. It's the classic flash pulmonary edema presentation of HFpEF. Think about iatrogenic things that cause volume retention. Keep in mind AFib is a really common cause of decompensated HFpEF. Ischemia probably plays a role in some patients. And think about comorbidities. Anything that stresses their system can throw them into heart failure, a pneumonia, UTI, a GI bleed, etc. So that's pretty easy in the hospital. What's much more difficult is an elderly patient presents with dyspnea. And if you get the echo and their EF's 20%, you'll say, oh, you've got heart failure. If you get the echo and the EF's 65%, then you have a little bit more work to do to figure out, is this just deconditioning and obesity or something else, or is this really HFpEF? So you're going to start with that echo, and for the boards, you're going to look for them to give you a normal EF, normal LV size, maybe some LVH, a big left atrium. They can have wall motion abnormalities or not, and then they'll give you some information about their Doppler diastology. Keep in mind, LVH may not be apparent in real life. So when they give you all those parameters, what you want to do is say, well, does the diastology fit the clinical situation that they've outlined in the tree? And if they present with just exertional symptoms, really they can have almost any of these patterns, but it wouldn't be unusual for them just to have impaired relaxation. But if they're telling you that the patient is dyspneic at rest, class 4, they should have a pseudonormal or restrictive pattern. So kind of look if they fit up, or is this a patient with a PE or lung disease or something that they're trying to trick you with. So you've got to really match the diastology to the clinical situation and see if it fits. Now, there's lots of BNP values on the boards. Lots and lots of studies have shown that in HFpEF, BNP values are about 1/3 to 1/2 of the values that you see in systolic heart failure. And they can be normal, especially if the patient only has exertional symptoms where they're just getting a transient elevation in their atrial pressure, or if they're obese. Obesity decreases the production of natriuretic peptides. But really the most fundamental reason why their BNP levels are lower is that BNP is produced by the myocytes in response to increases in wall stress. And as you remember, wall stress is proportional to pressure times the radius divided by the wall thickness. So systolic heart failure, huge radius, smaller wall thickness, you're going to have a huge wall stress. HFpEF, smaller cavity, greater wall thickness, wall stress is going to be much less. So you're going to have, even if you have an equivalent elevation in pressures. And this study just shows this very nicely. Diastolic heart failure, much lower BNP values, end diastolic pressures identical, but lower systolic and diastolic wall stress. So that's why patients with HFpEF have much lower natriuretic peptide levels. So if you're on the boards and the BNP is normal or a lot less than you would think of for the severity of the heart failure, think HFpEF or obesity. All right, so how do you manage these patients? Kind of the most unsatisfying part of the talk. And we'll go over the clinical trials. Basically, 3 trials looked at, 2 of them at ARBS and 1 of them at ACE in HFpEF, and none of them showed a difference in their primary endpoint, which was usually a combination of death and cardiovascular or heart failure hospitalization. And a nice meta-analysis puts this all together, these 3 trials in 8,000 patients, no significant effect on heart failure hospitalization or mortality. Maybe a trend to fewer heart failure hospitalizations, and that's why the new guidelines, the 2013 guidelines, say class 2B consider an ACE or an ARB to decrease heart failure hospitalizations, but it's not a very strong recommendation. What about aldosterone antagonists? Well, we only have the TopCat trial recently published, and patients with HFpEF treated with an aldosterone antagonist did not have a significantly lower rate of cardiovascular death, heart failure hospitalization, or cardiac arrest, which was the primary endpoint. If you just looked at heart failure hospitalization, there was a slightly lower rate with a p-value of 0.04, but this was the primary endpoint. And if you actually looked in the supplemental methods, all-cause hospitalization was not different between the two treatments because most likely aldosterone antagonists had a dramatic increase in the incidence of renal dysfunction and hyperkalemia. So events related to that probably kind of washed away the benefit of the improvement in heart failure hospitalization. There were lots and lots of issues with this trial. I don't have time to go into them, but neither the 2009 nor the 2013 guidelines covered aldosterone antagonists for HFpEF, so they shouldn't hit you with that. Beta blockers, almost no studies. The one we had was the seniors trial, and that was a study where they just took heart failure, and you could have any EF, and randomize them to nebivolol or not, and that was a very positive trial. And they said there was no interaction between the treatment effect and ejection fraction, but that was kind of based cutting the EF at 35%. And actually, there were very few true HFpEF patients in that trial. So we basically just don't know about beta blockers, although most patients, probably about 70–75% of HFpEF patients, are already on a beta blocker for some other reason. The DIDGE trial also looked at a cohort of patients with HFpEF. DIDGE had no effect on mortality. Patients with HFpEF treated with DIDGE did have fewer heart failure hospitalizations, but they had more hospitalizations for acute coronary syndromes. There has been a lot of interest in looking at pulmonary vasodilators, not really to just target the pulmonary vasculature, but because there was a lot of evidence that suggested these drugs, specifically PDE5 inhibition, had pleiotropic effects. And the largest trial was the RELAX trial, which was negative. There's just been another trial published in patients with hemodynamically confirmed HFpEF and pulmonary hypertension that didn't show a benefit. But there was this one study, small single center study, in a very unique group of patients with massive LV hypertrophy that did show a benefit. But right now, we don't recommend PDE5 inhibitors in HFpEF. If you're looking for something that you can do, and I think this could be on the boards, is exercise training for patients with HFpEF. Numerous studies in this meta-analysis have shown that exercise training improves exercise capacity and symptoms in HFpEF. Unfortunately, while heart failure is now an indication for cardiac rehab and you can get it paid for, it's only systolic heart failure that's covered with that, which is a bummer. All right, treatment then. The guidelines haven't changed a lot. I'm going to show you what the 2009 guidelines show and then any slight modifications that were present in the 2013 guidelines. So the class 1 things, the thing that you should always do, of course, is control the blood pressure. If they're in AFibs, make sure the heart rate's controlled, and diuretics. Now, in 2009, they just said control blood pressure. In 2013, they said you should use ACE, ARB, or beta blocker as your antihypertensive of choice if the patient has HFpEF. Not per se to treat their HFpEF, but to control their blood pressure. So that's the 2013 guideline. 2A recommendations are if they've got coronary disease and ischemia, coronary revascularization or medical therapy for their coronary disease is a 2A recommendation. So treat their hypertension, treat their AFib, diurese them if they need it, treat their coronary disease. And then we get into the class 2B. And in 2009, restoration of sinus rhythm, so rhythm control was a 2B if the patient still had HFpEF symptoms when their rate was controlled. And the 2013 guidelines moves this up to a class 2A. So if you have a patient comes in with AFib, you get them controlled, their rate controlled, their heart failure treated, but they're still symptomatic, you can consider a trial of rate control with a 2A recommendation. And then the 2009 guidelines said, well, if their blood pressure is controlled, you could try these agents, ACEs, beta blockers, calcium blockers. It might help symptoms, but the 2013 guidelines don't say that anymore. So the safe answer, if they're trying to get you to use an ACE or an ARB or a beta blocker, only if there's an other indication for it. And if it's just diuretics in the presence of volume overload versus these agents, go with the diuretics. That's the class 1 recommendation. So I've kind of put down the pearls there for you at the end, which you can review. And we're going to talk about a couple of these things during the questions, especially how to look for the zebras and some of the finer points of treatment. All right, thank you. All right.
Great job, yeah. Go ahead and advance, and we'll do the pre-test questions, and then she's got some additional questions that we'll go through as well. So, got these two patients with remarkably similar hemodynamics admitted to your CCU one night. Wedge of 28, RA pressure of 20, heart rate of 80, cardiac output of 3.5, and which one's going to respond to nipride? The person with the normal sized ventricle, normal EF, and high blood pressure, or the person with the huge ventricle, low EF, and lowish blood pressure?
Much better.
Much better. Not
Now,
the 50-50 split.
Now, you may want to give the HFpEF patient something to get their blood pressure down, but if you're looking at who's going to get the greatest improvement in cardiac output, it's going to be the HFrEF patient, okay? So that's the famous Schwarzenberg-Borlaug paper that very nicely demonstrated that. Okay.
There it is.
Okay, so and that's why we can use vasodilators in systolic heart failure, get less drop in blood pressure, but a big increase in cardiac output. In HFpEF, we get the bigger drop in blood pressure and less of a benefit in cardiac output.
Okay, question number 2 is a 72-year-old obese male with type 2 diabetes, sleep apnea, and shortness of breath. NT-proBNP is 100. Normal LV size, EF, mild RV enlargement. So the EA ratio is 1.6 with a deceleration time of 125. E prime is 0.04, E over E prime is 20. Systolic pulmonary vein velocity is 0.5, diastolic is 0.8, and the PASP is estimated at 60. And the question is, what does that echo show us? Is it high filling pressures and normal relaxation? Is it normal filling pressure and impaired relaxation? Is it both high filling pressures and impaired relaxation? Are they both normal? Or is it group 3 pulmonary hypertension?
Great.
Excellent.
I think we were 93% before, so we went up to 97%.
It's a lift. We call that a lift.
At least it didn't go the wrong way.
Yeah.
All right, so you guys got that. And just kind of review this progression, and it seems like you have a good grasp on that. All right. And I think the other fine point is, again, fits in with what Dr. France likely covered. Pulmonary hypertension is so common, and HFpEF patients have it, but everybody has sleep apnea now, and they've got a little bit of COPD, and really figuring out how much is the HFpEF and how much is the group 3 can be difficult. But patients with obstructive sleep apnea, true pulmonary hypertension is pretty unusual unless they're just very hypoxic all night long. And patients with COPD, the same thing. Unless it's really severe COPD, the pulmonary hypertension is unusual. So the HFpEF, in that if you have HFpEF, a little bit of COPD, and some sleep apnea that's treated, the HFpEF would be the most likely cause of the pulmonary hypertension.
Okay, question 3 is a 74-year-old male with slowly progressive exertional dyspnea, treated hypertension, no chest pain, never smoker. He has normal coronaries. He's on a diuretic, an ACE inhibitor, and a calcium channel vasodilator. His blood pressure is 160, heart rate 65. His heart is big, but his lungs are clear. He did an exercise sestamibi with severe dyspnea, but no ischemia. There's his mitral inflow. His EF is normal. His RV is normal. So what is the next step in his management? Is it change his diuretic to furosemide? Is it add a beta blocker? Is it stop the enalapril? Is it chest CT for pulmonary embolus or pulmonary function testing?
All right, I think we made a little improvement. I think it was about 60-40 or something before. So I would say the right answer is add a beta blocker. Because he was tachycardic with exercise. Remember here, does the diastology fit the symptoms? He doesn't have rest symptoms. He just gets short of breath with exertion. And he has, on the mitral inflow, a very impaired relaxation. So it gets down to this. You see, he really takes his whole diastolic filling period to fill his ventricle. So with tachycardia, he's going to have less time to fill. So again, here, with normal heart rate and impaired relaxation, the diastolic pressures aren't high. But with tachycardia and impaired relaxation, the diastolic pressures go very high. So the key here is to treat the fast heart rate. So I would have said do the beta blockers to slow his heart rate with exertion. So if they have this kind of a pattern and exertional symptoms, then is when it would be appropriate to try and slow him down. If they're restrictive and have this type of the pattern, you see all their filling occurs in early diastole. So slowing them down is not really going to help. It's just going to drop their cardiac output. But if they're needing their whole diastolic filling period to fill because of impaired relaxation, these are the patients to think about a negative or chronotropic agent.
Some of them should have heard this last Friday morning.
All right.
They might remember that from the lecture on diastolic function at the echo portion.
Okay.
But that's the important thing. Slow that heart rate down if they have that impaired relaxation problem. They can fill better.
All right.
Question number 4, a previously active 76-year-old woman presents to the emergency department with recent onset dyspnea, orthopnea, edema, and tachypalpitations. She's treated for hypertension and diabetes. She has AFib with RVR. Her heart rate's 130. It's new. Her EF is normal. Her left atrium's big. LV is otherwise normal, and the valves are normal. She has 30% lesions on her coronary angiogram. She's given IV diuretics, heparin, Coumadin, and beta blocker. In follow-up, her NAF, her heart rate is 60 at rest and 86 with a 6-minute walk test. Her blood pressure is normal. She appears euvolemic but complains of persistent dyspnea on exertion. That's her medication list down there at the bottom. The next best step is to A, increase her diuretic, B, add amlodipine, C, a trial of rhythm control, D, increase the metoprolol, or D, decrease the metoprolol.
I think I put the, sorry. I thought I had them. I should have put the meds here.
You can go backwards,
Yeah.
show them the previous. They did pretty well. 89% trial of rhythm control.
Perfect. So now that's class 2A in the guidelines. Yeah, she's, and that's, you probably heard in the AFib guidelines. So this would be appropriate to consider a trial of rhythm control for symptom improvement. And we wouldn't really increase furosemide because she's euvolemic. No reason to add amlodipine because her blood pressure was controlled, and no reason to change her metoprolol because her heart rate was neither too slow nor too fast. Okay?
All right. A 39-year-old man is referred progressive dyspnea, no history of hypertension or smoking, and no other risk factors. His exam is unremarkable. His EF is normal. His LV size is normal. He's got increased wall thickness, a small effusion, and his mitral inflow pattern shows what's on the left. His tissue Doppler is on the right.
It's his E there.
Here's his ECG. Your next step is CT for pericardial thickness, monoclonal proteins and fat aspirate, coronary angiography, iron studies, or genetic testing for mutations for HCM. I'm going to go back and show him that ECG. And
There's the EKG. And there's the mitral inflow. Perfect.
good.
Enough said. So, a young person, think about the zebras, hypertrophic cardiomyopathy, constrictive pericarditis, and restrictive cardiomyopathy, which can be either familial or more commonly in our practice, cardiac amyloidosis. And so I know you've heard about that. So that's very pertinent into the HFpEF clinic. We see a lot of patients with amyloid and think about those.
So just to kind of review, what is your base workup for someone that shows up with heart failure symptoms and restrictive filling pattern?
Oh, there's not a generic. It depends on, if the patient, the history, the clinical history, if they have hypertension. So we evaluate them for all the different underlying cardiovascular abnormalities, coronary disease, hypertension, diabetes, hyperlipidemia, such. And then what treatments they're on. We always look for ischemia. We think about amyloid if the increase in the wall thickness is out of proportion to their hypertension history, or they're an elderly male. We think about senile amyloid. We're getting a lot of MRIs or pyrophosphate scans for that. We do screen for amyloid with light chains or the monoclonal proteins. Kind of basic.
Okay. Question 6 is a 50-year-old woman complaining of dyspnea on exertion. She is obese. She has limited activity due to DJD. Her blood pressure is 130/60. EF is 68, and her mitral inflow pattern looks like this. Her E over E prime is 10. Which of the following statements is true? A, her left atrial pressure is increased. B, her tau is increased. C, both A and B are true. Or D, you need further information to characterize her diastolic function and filling pressure.
All right. So maybe a little more work on the diastology after all. So she is indeterminate. I think I'll go back here. Her E to A ratio is about 1. So kind of in that, is it normal or is it pseudo-normal? And her E to E prime ratio is kind of in the indeterminate range. It's not greater than 15, it's not less than 8. So really not enough to hang your hat on here. So we'd need to do something else. Valsalva, look at her pulmonary veins, look at her pulmonary pressure, look at her left atrial volume.
All right, question number 7. A 74-year-old female presents with severe exertional dyspnea. Hypertension and diabetes are present. Her sister died at age 55 from idiopathic pulmonary arterial hypertension. She's on lisinopril, Lasix, and amlodipine. Her echo shows mild LVH and EF of 70, left atrial enlargement, PA pressure of 70, RV is enlarged and hypokinetic. ANA, VQ scan, and adenosine sestamib are all negative. What should you do next? Add DIG, a right heart cath, sildenafil, bosentan, or genetic testing for BMP receptor mutations.
That's bone morphogenic protein. Excellent.
Nice.
Dr. France did a great job. So, right heart cath, right. This is kind of a nice algorithm that the pulmonary arterial hypertension group published. If you have an elderly person and they've got all the risk factors and they look like diastolic heart failure, you don't always need a right heart cath, even if they've got some pulmonary hypertension. Likewise, if it's a 24-year-old woman and everything looks like it, you'll just go ahead to right heart cath. But there's a lot of patients that you're just not certain. Now, in this patient with the family history, occasionally group 1 can present late in life, so I think it would be appropriate to do a right heart cath, even though she had sort of a typical HFpEF history. So you would want to go ahead and do the right heart cath would be the most appropriate things out of those options.
Ooh.
So
Sub-question B. Patient undergoes a right heart cath. The PA pressure is 60/27 with a mean of 38. The wedge is 25 with a SAT of 94, and the output is 5. The most appropriate next step is to add sildenafil, increase lisinopril, add bosentan, increase furosemide, or do a pulmonary angiogram.
Excellent. 75% of you got it right, yes. So the first thing you're doing is quickly calculating. So they have pulmonary hypertension. The mean PA pressure is greater than 25, and they have a high wedge pressure. And you calculate the PVR. That's going to be 13 divided by 5. That's going to be less than 3 Wood units. So it's group 2 pulmonary hypertension due to the high wedge pressure. So you want to increase the furosemide. And again, this is how the guidelines for separating pulmonary arterial hypertension from pulmonary venous hypertension, and her wedge was over 15, her PVR was less than 3, so pretty straightforward. This is just pulmonary hypertension due to pulmonary venous hypertension.
All right. Thank you so much, Maggie. Excellent job.